Assalamu alaikum. Do I have my students with me? Do I have my students with me, please? I want a response so that I can start the presentation. Assalamu alaikum. I am Dr. Farah Idris, and this is my first experience with you as an online teaching. So I hope we have a good session. Our topic of today is cholelithiasis presentation and its sequelae with its management. So let me make it clear, since this is an online presentation, the presentation has been edited with the help of different free online power presentations available on the net. The topic of today, what will we be discussing? The objectives, the presentation of cholelithiasis, types of gallstones, complications, management, summary, and obviously references. Why the gallbladder? We will be looking at the surgical anatomy and the physiology of the gallbladder. Why do gallstones form? How do gallstones present? And what is the management of these gallstones? The learning objectives will be discussing the introduction, types of gallstones, factors associated with gallstone formation, clinical presentation, the sequelae, complications of gallstones, severity of acute cholecystitis, the differential diagnosis of acute cholelithiasis, diagnosis and treatment. Before going on to the topic, let's just discuss the surgical anatomy of the gallbladder. It is located between the junction of the right 9th costal cartilage and lateral to the rectus abdominis, approximately 2 centimeters from the lateral margin. It is a pear-shaped sac lying on the inferior surface of the liver in a fossa between the right and the caudate lobes, and the capacity is approximately about 30 to 50 ml. You can see the gallbladder is lying in the liver bed. This is the cystic duct opening into the hepatic. So this is an overview of a gross appearance. This is the gallbladder basically, and this is the caudate lobe and the right lobe. Something about the biliary system. Now, this is the right and the left biliary ducts, which form the common hepatic duct, and into that opens the cystic duct. This commonly then is known as the common bile duct, which opens into the second part of the duodenum and it is controlled by the hepatopancreatic ampulla. Now, the gallbladder measures approximately 8 centimeters in length and is 4 centimeters in diameter when fully distended. The course of the common bile duct is supraduodenal, the retroduodenal, that is behind, then infraduodenal, that is below, and then intraduodenal, that is, this part is opening, this is the intraduodenal. Now, when we're discussing the anatomy of the cystic duct and the gallbladder, there's a common surgical area which is important, and that is the Gallstone triangle. The Gallstone triangle is basically bounded by the lateral edge of the common hepatic duct, superiorly by the inferior border of the liver and the cystic duct. The contents is basically the cystic artery, which is very important, as we need to ligate this before we dissect this cystic duct for when we do cholecystectomy. Sometimes you will be coming across this name of Moynihan's hump. This is basically a curvature of the right hepatic artery, and this is a very small stump of the cystic artery, and sometimes this is ligated instead of cystic artery. So this Moynihan's hump is important with that reference. Something to talk about the blood and the lymphatics of the gallbladder. So basically the common hepatic duct gives the proper hepatic artery, and then it divides into the right and left, giving off the cystic artery from the hepatic duct. Then we have this lymphatic drainage. It usually drains into the cystic node, and from the right lobe of the liver, everything almost into the duodenal part. Venous drainage, the cystic veins draining the neck of the gallbladder and the cystic duct enter the liver directly or drain through the portal vein to the liver. The veins from the body of the gallbladder pass directly into the visceral surface of the liver and drain into the hepatic sinusoids. Now, this venous drainage is important when we're talking about the malignancies. Obviously, we know that the lymphatics and the blood supply, which is draining that area, is the route of spread of malignancy. Nerve supply, basically it's supplied by the sympathetic and the parasympathetic, the celiac nerve plexus, which is carrying the afferent pain fibers, which is important when we come across cholecystitis pain, the vagus carrying out the parasympathetic, and the right phrenic nerve actually which carries the somatic afferent fibers. Now some physiology. Now the bile is produced at a rate of about 500 to 1500 mils per day by the hepatocytes and the cells of the duct. The composition of the bile is basically bilirubin is a byproduct of heme degradation. Cholesterol, which is produced in the liver cells, is kept soluble by the bile salts and the lecithin. The boiled salts, which are basically the cholic acid and the oxycholic acid, is usually absorbed by the terminal ileum by the enterohepatic circulation. The lecithin increases the solubility of the cholesterol. The inorganic salts, which are composed of sodium bicarbonate to bile, to keep the bile alkaline, to neutralize the gastric acid in the duodenum. And the water content is approximately about 97%. Now, this is a sketch which is basically depicting the formation, which is about 70% of the bile is composed of bile salts and acids, 10% is the cholesterol, 5% phospholipids, 5% proteins, 1% bilirubin, and some amounts of electrolytes and bicarbonates. All of this is produced in the liver, and then it is stored in the gallbladder and then sent from there into the small intestine. Now, something to show about the circulation, secretion and the enterohepatic circulation of the bile salts. Basically, the bile is being produced in the liver. It is then secreted, which stores into the gallbladder. The ions in the water is reabsorbed from the gallbladder. Then the bile is then secreted from the gallbladder after the intestine secretes cholecystokinin, and then the bile is secreted to the small intestine, and from there the bile salts are reabsorbed through the portal circulation into the liver again. Now, this is the enterohepatic circulation, and we are going to come across when there is pathologies at what level that stone formation occurs. Now, this is a depiction showing the difference in bile composition in the liver and the gallbladder. As you can see, there's a minute difference about concentration of everything, every element in the gallbladder. It is basically an area where some absorption occurs, and the water content reduces from 97 to 92, and so forth. The bile salt, everything is being actually concentrated. The definition, gallstones. The presence of gallstones in the gallbladder is referred to cholelithiasis. It is risen from the word Greek chole meaning bile, lith means stone, and asis means the process. If the gallstones migrate into the duct of the biliary tract, the condition is known as cholelithiasis. This is cholelithiasis, and this is cholelithiasis, that is stone in the biliary channels. The gallstones are the most common biliary pathology. They are asymptomatic in majority of the cases, that is about 80%. But approximately 1 to 2% of these asymptomatic patients will develop symptoms who will require surgery, and therefore cholecystectomy is one of the most common operations performed by general surgeons all over the world. What are the risk factors? Multiple risk factors. Women, multiparity, drugs consisting of birth control pills or HRTs, and even drugs like ceftriaxones precipitate stones. Pregnancy, family history, first degree relatives, so it will be common in them, hemolytic anemias or sickle cell anemias, obesity or hyperlipidemia, ileum diseases like inflammatory bowel disease or resection of the terminal ileum or any bypass surgery will be precipitating stones. Diabetes, infection, or any biliary stasis will precipitate stones. A sedentary life obviously will also have a part. Liver disease like cirrhosis, total parenteral nutrition, and a rapid weight loss. I should mention a rapid weight loss will also precipitate stones. Now, what are the predisposing factors? The predisposing factors, as we can see in females usually is fat, body, female, and fertile. At some time it used to be fair also, but now due to environmental changes and habits, this fair complexion has changed, and it is now even common not just in females, it is evenly common in males also. So what are the factors associated with gallstone formation? There are four major factors, that is impaired gallbladder function, in which there will be impaired emptying, absorption or excretion, supersaturated bile, in which age is a factor, as we said, sedentary life, as the person grows older, the reflexes and the smooth muscles tend to relax. The sex, I don't know, I think it is now equally common in both the sexes. Obesity and a diet. Again, cholesterol nucleating factors, in which mucus and glycoprotein ratio will have an impact. Infection, absorption and enterohepatic circulation of the bile. The amount of deoxycholate will be decreased. Bowel transit time, if it is impaired, so enterohepatic absorption will be impaired. Fecal enteric flora, ileal resection, and cholestyramine, all these have factors in stone formation. Another picture which is depicting this is basically to clarify what are the different precipitating factors for stone formation. So it may be a lithogenic bile, which is seen in increased cholesterol diet or obesity, because there is a decrease in bile acids as seen in OCPs and genetic factors, primary biliary cirrhosis, ileal disease or ileal resections, increased bilirubin as seen in hemolytic anemias. Excess nucleation can occur, excess pro-nucleating factors, example mucin. Decreased anti-nucleating factors like apolipoproteins, these will all precipitate stone formation. Stasis or hypomotility of the gallbladder. Hypomotility of the gallbladder will be precipitated by oral contraceptive pills, vagotomy, fasting, pregnancy, prolonged parenteral nutrition. What are the different types of stones? As you can see, these are the cholesterol stones, in which you will see the color will usually be pale color and they will be multifaceted like this. They will be cornered up smooth surfaces. These are cholesterol stones. The pigment stones are irregular surfaced, and as you can see, there are concretions. They are layered actually. We are going to see the detail later on in the slides. Mixed stones means a composition of cholesterol and pigment stones. These form pigment stones. Now you can see that in both these pigment and the mixed stones, their surfaces are irregular. While in the cholesterol stones, they are smooth. So what are the causes of cholesterol stones? That is supersaturated bile, usually in obesity, high calorie diet, oral contraceptives, resection of the terminal ileum. I know there's a lot of repetition in the slides, but basically it's to clear your concept that we are not interacting. Otherwise, in a face-to-face class, I usually interact. That's why I've made a bit of a detailed presentation. So a little bit of cholesterol stones. Cholesterol is basically secreted from the canalicular membrane in the phospholipid vesicles, and the micelles formed by the phospholipid hold the cholesterol in a stable thermodynamic state. This is the normal state. But when the bile is supersaturated or the bile acid concentrations are low, unstable unilamellar phospholipid vesicles form, and these then precipitate to form stone. When the cholesterol is greater than 50% composition, crystals may nucleate with calcium or bile pigments and stones may form. Pure cholesterol stones are less than 10% of all stones. So majority of the cases you will be coming across mixed stones or basically pigment stones. This is again a picture depicting the gallstones, different types of stones. Cholesterol is precipitated due to supersaturation, as these micelles cannot hold, and eventually these are the bile salts basically which is trying to hold on to that. But then obviously when the concentration increases, they will form into bilirubin stones or cholesterol stones. Now, what are the causes of pigment stones? Pigment stones are basically due to hemolysis as seen in hereditary spherocytosis, sickle cell disease, or in cirrhosis. The pigment stones basically, as the name says, is basically containing less than 30% of cholesterol. There may be two types, which may be black or brown. What are the characteristics? Now, the black stones are composed of insoluble bilirubin pigment, which is a polymer mixed with calcium phosphate and calcium bilirubinate. Now, this difference is the difference between the brown and the black stones. The black stones will be containing calcium phosphate and calcium bilirubinate associated with hemolysis. Okay, I have someone asking me to go a bit slow. Okay, so the black stones are basically associated with hemolysis, usually hereditary spherocytosis or sickle cell disease, and patients with cirrhosis. Now, these will be forming pigment stones. The brown stones may contain calcium bilirubinate, calcium palmitate, and calcium stearate, and cholesterol, obviously. As we had told earlier on that approximately if the cholesterol is less than 30%, then all of them will be aggregating with the other ions like calcium stearate and calcium palmitate. They form in the bile duct related to bile stasis, infected bile, foreign bodies within the bile duct as endoprosthesis-like stents as we use sometimes, or parasites such as Coronesis senesis or Ascaris lumbricoides also can be a cause of stone formation in the common bile duct. The bacteria responsible for the infection enzymatically catalyze the conversion of bilirubin glucuronide to form insoluble unconjugated bilirubin. So something about mixed stones. The mixed stones are again formed because of infected bile, as we had deteriorated, because either they are forming pigment stones or they are forming mixed stones. They are almost comparatively the same. As I told earlier, basically it is the composition of the calcium palmitate or calcium stearate that makes the color difference. So the precipitating cause might be the same thing. It may be infected bile, foreign bodies in the common bile duct as stents or parasites, as we have discussed earlier on. Something about mixed stones. They are the most common type, and it may be a combination of cholesterol and pigment stone or either of these with some other substances. So as we said, calcium carbonate, phosphate, bile salts, and palmitate may make up more more common minor constituents. So what is cholelithiasis? The cholelithiasis may be asymptomatic or it may be symptomatic. In symptomatic, it may be chronic calculous cholecystitis or acute calculous cholecystitis. Clinical presentation of gallstones would be gallstones may remain asymptomatic, being detected incidentally as an imaging is performed for some other symptoms. Now, if the symptoms occur, patient typically complains of right upper quadrant or epigastric pain, which may radiate to the back. This may be described as colicky, but more often it is dull and constant. Other symptoms include dyspepsia, flatulence, food intolerance, particularly to fats, and some alteration in the bowel habits. Can anyone tell me what flatulence is? May I have feedback on what is flatulence or dyspepsia? Any comments, please? Can anyone comment on dyspepsia, flatulence of food intolerance? What type of food? Yes, Kola is quite correct. That is basically gas production due to improper digestion. It's nothing to do with passage of air from the mouth or bloating, basically. Okay, let's. So what are the common sequelae of gallstones? It will be presenting as biliary colic, acute cholecystitis, cholelithiasis, and cholangitis. These two are basically related to the gallbladder, and these two are related basically to the biliary channels. So what is biliary colic? It is basically intermittent obstruction of the cystic duct. There is no inflammation of the gallbladder mucosa, and the patient may be presenting with severe, poorly localized epigastric or right upper quadrant visceral pain, growing in intensity over 15 minutes and then remaining constant for 1 to 6 hours. There may be intermittent jaundice with pale stools or dark urine. The differential diagnosis is renal colic, intestinal obstruction, and even angina, because now what we had discussed earlier on, the nerve supply is primarily the cause root of referred pain, basically. So the nerves are basically the same. So you may even have angina, and the symptom will be right upper quadrant pain or discomfort, epigastric discomfort, basically. Now, the pain episode may resolve when the stone is passed into the common bile duct or it falls back into the gallbladder. The symptoms will subside automatically. So this is biliary colic. Basically, the stone in the cystic duct lodges after eating fatty meal. If the gallbladder is containing stones and it contracts and there's a large stone, it might get stuck in the cystic duct, and that may precipitate the biliary colic. So there may be a sharp right upper quadrant pain, which may subside when the gallstone subsides, when the gallstone dislodges and falls either back into the gallbladder or into the biliary system. So what is acute cholecystitis? When the stone is impacted in the cystic duct, there is acute inflammation of the gallbladder mucosa. The symptoms will be visceral epigastric pain, which may be severe, constant, localized in the right upper quadrant, referring to the back and the shoulder. Severity, how the patient may present, maybe with fever, toxemia, rigors, There might be leukocytosis. On examination, you will be finding tenderness in the right hypochondrium, and this Murphy sign will be positive. We'll be discussing what Murphy sign is later on. And on physical examination, there may be a palpable gallbladder. As you can see in the previous picture, this stone impacted over here will impair the secretions from going into the biliary channel, and it will cause swelling of the gallbladder. The question will be, if there is no bile coming into the gallbladder, how is it going to swell up? So basically, the mucosa keeps secreting into the gallbladder and accumulates, and that's why when it will not be passing out, it will be collecting and we will have a palpable gallbladder. What are the complications of acute cholecystitis? There might be empyema. Empyema is that if you have a collected distended gallbladder and it gets infected, then that is empyema. If it is not infected, then it is called a mucoseme. You may get a perforation of the gallbladder. You may even get obstructive jaundice, and there might be acalculous cholecystitis. By acalculous, we mean that there is no stone, but there is infection of the wall of the gallbladder. We're going to see more in a picture form in the later slides. Now, this is a very good guideline for severity of grading acute cholecystitis. The mildest form is basically grade 1. It does not meet the criteria of grade 2 or 3, which will be seen further on. Basically, the grade 3 is the most severe form of acute cholecystitis. Acute cholecystitis is just inflammation of the gallbladder. There's nothing to do with the stone. It is just inflammation of the wall of the gallbladder that we call it as acute cholecystitis. Now, the associated dysfunction of any one of the following organs is in severe cholecystitis. Cardiovascular dysfunction will occur, that is hypertension, neurological dysfunction, decreased level of consciousness, respiratory dysfunction, when the FiO2 will be less than 300, renal dysfunction, oliguria, or the creatinine is rising to greater than 2 milligram per deciliter, hepatic dysfunction, prothrombin time is greater than 1.5, hematological dysfunctions, when the platelet count is when the hematological dysfunction with the platelet count is greater than 100,000. So these are grade 3 when the other systems are involved. And these are the criteria where you would see for the involvement of the organs. In grade 2, acute cholecystitis associated with any one of the, that is apart from right hypochondrial pain and nausea and vomiting, you might be having an elevated white cell count of greater than 18,000. A palpable tender mass in the right upper quadrant. Duration of the complaint is greater than 72 hours. And there will be a marked local inflammation. That is in the gallbladder. There may be gangrenous cholecystitis, pericholecystic abscess, hepatic abscess, biliary peritonitis, or even emphysematous cholecystitis. I am going to show you a picture of emphysematous cholecystitis in my presentation ahead. Now, basically, what I mean to say, if the patient is presenting with right hypochondrial pain and fever, these are the other added things that if you are going to come across, then you will be suspecting as grade 2 moderate cholecystitis. Milder form does not meet the criteria of grade 2 or 3. Grade 1 can be defined as acute in healthy person with no organ dysfunction or mild inflammatory changes in the gallbladder, making cholecystectomy a safe and low-risk operative procedure. So what is choledocholitis? That is intermittent obstruction of the common bile duct. The symptoms are indistinguishable from the biliary colic. Predisposes to cholangitis and acute pancreatitis. We're going to come across how cholangitis and acute pancreatitis might be occurring. In cholangitis, Basically, that is cholangitis, meaning the inflammation of the biliary channels. Chole, again, as I said, is basically gallbladder, and this channel system, chole is basically defined as bile, they say, as in Greek word. So, impacted stone in the common bile duct causing bile stasis. This will lead to bacterial superinfection of the stagnant bile, and a typical Charcot striate occurs. If this is occurring, then obviously patient is suffering from cholangitis. There may be pain, jaundice accompanied by fever. There might be even chills or rigors when the cholangitis occurs. The patient will be complaining of chills intermittently. It may not be associated with fever, but it will show the impact that there is retrograde efflux of bile into the biliary channels. Now, what are the complications of cholelithiasis? There are multiple complications, right, from the liver, as we had seen, discussed earlier on. There may be cholangitis. If there is stasis, there might be even abscess formation in the liver. At the level of the gallbladder, there may be inflammation leading to cholecystitis. As I told earlier, if there's impaction at the neck of the gallbladder, there is no secretion of bile coming in or going out. Eventually, some of the bile will get absorbed, and this mucosa will keep secreting mucus. So there may be a mucocele formation. There might even be due to friction of the stones. Long-term basis, we do not consider stones to be safe, and it can be a cause for carcinoma because of the friction of this large stone with the wall of the gallbladder. Because every time the gallbladder contracts, these large stones cause friction with the wall, and this might precipitate carcinoma. Now, when this gallstone trickles from the bile, from the biliary channels and comes and lodges in this area, it might cause pancreatitis. There might even be gallstone ileus. When the stone either perforates from the gallbladder fundus into the intestine as a duodenum, it may cause gallstone ileus. Intermittent obstruction in cholelithiasis actually is the stone might be small. It is not necessary that the stone is very big and it will just go and stick over here. There might be a small stone which may trickle, and sometimes it will come and obstruct this and cause retrograde obstruction and cause jaundice. And sometimes as inflammation subsides, this may cause passage of the bile into the duodenum, and there might be intermittent jaundice. That's why intermittent jaundice occurs in cholelithiasis. Now, these are basically all the complications that may encounter with gallstones. We're going to see a pictorial view ahead in the next slides. So, the complications of the gallbladder, if we come across region-wise in the gallbladder, the complications may be acute cholecystitis, chronic cholecystitis, empyema of the gallbladder, mucocele, as I told you earlier. If the distended gallbladder contains just mucus secretion, it is known as the mucocele, and when it gets infected, it may form into an abscess like bag, and it is known as an empyema. And in this, the patient will have all the toxic symptoms of high-grade fever and toxicity, while in mucocele, we may just have pain and palpable gallbladder, but no constitutional symptoms of fever or as such. Now, due to the distension of this gallbladder, there might be ischemia and perforation may occur and may lead to biliary peritonitis. There may even be gangrene due to ischemic necrosis of the gallbladder wall, and in long-term carcinoma can occur in the gallbladder. In the bile ducts, you may have biliary colic, or you may even have obstructive jaundice, cholangitis, or acute pancreatitis. In the intestine, it may present as acute intestinal obstruction due to gallstone ileus. Now, this is a pictorial view demonstrating how obstructive jaundice can occur when the stone gets impacted into the common hepatic duct or the common bile duct. It may cause retrograde efflux of the bile into the liver again, and from there, from the circulation and absorption of the bile, it will lead to obstructive jaundice. Sometimes it also happens that this gallbladder gets a stone impacted at the neck of the gallbladder, and this may cause narrowing of the channels, and again, patient may present with obstructive jaundice. What happens in cholangitis basically is that along with obstruction and biliary stasis, there is ascending infection, and this will lead to endotoxemia, and reciprocal multi-organ failure will occur even to the extent that renal failure can present in obstructive jaundice. Again, as we had seen, obstruction since the common bile duct, there are variations, and sometimes the main pancreatic duct opens along with the common hepatic duct, and that opens into the duodenum, second part of the duodenum. If a stone comes and gets impacted at this junction, as we had seen earlier on, that the interduodenal part, this may cause efflux of pancreatic secretion retrogradely and eventually inflammation of the pancreas leading to pancreatitis, acute pancreatitis. Now, this is gallstone ileus. A big stone cannot travel through the cystic duct commonly. So the other route is that, as we had seen earlier on, that the fundus of the gallbladder rests on the second part of the duodenum. This inflammatory process may cause the gallbladder to rest on the duodenum. And due to this inflammatory process, it may perforate. If there is narrowing of this area, eventually this may perforate due to ischemia, and the stone may trickle into the intestines. Now, this is a pictorial view showing gallstone ileus. Gallstones may erode into the duodenum or the colon. As you can see from this X-ray film, that this stone is in the bowel. The gallbladder lies in this area, but it has perforated and come into the intestine and is lying there. On intraoperative findings, you will find this stone in the small bowel. This is the small bowel, basically. Acute Cholecystitis. You may be mistaken for an appendicitis, or a perforated peptic ulcer, or even acute pancreatitis. These are obviously the same area where the gallbladder lies, basically. Appendicitis, we are saying because bile tends to trickle from the right paracolic gutter into the right iliac fossa. If there is small amount of leak, it may go and collect in the right iliac fossa and may give you the symptoms of appendicitis. Rare are acute pyelonephritis, even myocardial infarction, or pneumonia in the right lower lobe may present as a case of right upper quadrant pain, basically. So how do you make a diagnosis? A diagnosis of gallstone disease is based on the history and physical examination with confirmatory radiological studies. Now, there are a few terms that you'll be coming across, and you need to remember them. One is Murphy's sign. Now, what is Murphy's sign? It is an acute phase. In the acute phase, the patient may have right upper quadrant tenderness that is exacerbated by a patient taking a deep breath, and the right subcostal margin, you will feel the gallbladder and the patient will wince, basically. Or a mass may be palpable as the omentum walls of the inflamed gallbladder. Now we are running out of time. I'll be flying with the slides, basically. Courvoisier's sign is basically a palpable non-tender gallbladder resulting from distal obstruction secondary to a peripancreatic malignancy. So a palpable non-tender gallbladder is usually a sign of malignancy, and it is basically known as Courvoisier's sign. You should know this. Now you should need to differentiate between the mucocele and this palpable gallbladder. But the age and related symptoms will guide you, basically. A mucocele is a non-tender palpable gallbladder resulting from complete obstruction of the cystic duct with reabsorption of intraluminal bile salts and secretion of uninfected mucus by the gallbladder epithelium. Investigations: X-ray abdomen, ultrasound, radionucleotide imaging, cholecystography, ERCP, and ETC, percutaneous transhepatic cholangiogram. Now, if the gallstone is suspected, an abdominal X-ray will just show 15% of the gallstones because they are usually not calcified. So X-ray studies are not all that helpful. Now, this is basically a plain radiograph showing stones in the gallbladder. These are mixed stones, obviously, where calcium is deposited, and you can find them. Now, this is basically a differential diagnosis of a radiopaque shadow in the right upper quadrant area. So that can be a renal stone, that can be a calcified 12-rib tip, a phlebolith, a fecalith, calcified lymph nodes, or even renal cell carcinoma calcification may occur in this area, or a calcified adrenal tumor. This area is basically highlighted. If you have a radiopaque shadow in this area, you should consider differential diagnosis apart from gallstone. Now, this is a porcelain gallbladder. A porcelain gallbladder is that in which the whole of the gallbladder wall, the wall of the gallbladder calcium deposit occurs. There is no stone inside, but the wall is containing calcium deposit. This is known as the porcelain gallbladder, and it is a pre-malignant condition. Now, this is what I was saying, emphysematous gallbladder. If you can appreciate this radio dense area, the wall, hyperlucent area, like this is gas, and similarly you can see this gas in the wall. So this is emphysematous gallbladder, that is gas in the gallbladder wall. This is a surgical emergency, basically, and you need to operate on these patients. Now, ultrasound imaging demonstrates the gallbladder as a thin-walled white ring surrounding which is bile, appears as black fluid. This is the black fluid. The wall thickness is usually 3 mm. Normally, you can measure the diameter of the gallbladder wall on ultrasound, basically. So ultrasound has many advantages. It has replaced cholecystography, which is an invasive procedure, and it does not expose the patient to radiation. It is most accurate if the patient fasts overnight and the gallbladder is distended. It detects the calculi, and it is 90% accurate, and it even detects polyps, the diameter of the common bile duct, and any hepatic parenchymal abnormalities can be seen on ultrasound. The stones may be seen as dense acoustic shadows, and they change on posture. The stones may trickle from one side to the other if you change the posture, while as in polyps, they may be calcified and they will not change on posture. The thickness of the gallbladder and the local tenderness may indicate cholecystitis. A contracted, thick-walled gallbladder indicates chronic cholecystitis, and in obese patients, or in patients with ascites, there might be a compromised ultrasound. So ultrasound may have its own consequences as well. So in imaging studies, the ultrasound is 85% sensitive and specific 95% for gallstone disease. So what would we'll be looking on ultrasound? The gallstones, the pericholecystic fluid, the gallbladder wall thickness may be greater than 3 mm. And if you keep a probe, you may even elicit the Murphy sign. That is, the patient will wince on putting the probe on the gallbladder wall. Now, this is basically a large stone in the gallbladder. And it is showing the distal acoustic shadowing. The stone has, the rays fall on this, and therefore, since this will be obstructing the rays, so you will be finding this acoustic shadow on the lower end. There's again a disparity in the wall because this is obstructing, this stone is obstructing the passage of this one ray, the wavelength of the ultrasound. We're going to skip this because this is no more done. This is basically cholecystography, in which you used to give radio opaque dye orally, and then you this secreted and you could illuminate the gallbladder. So now cholecystography is usually taken place by the ultrasound. Now endoscopic retrograde cholangiopancreatography is something that permits visualization of the structures which could once be seen only on laparotomy. Examination of the hepatobiliary system is seen by a side-viewing flexible fiber optic endoscope inserted into the esophagus, and multiple position changes are required during the procedure in the left semi-prone position to pass the scope. Fluoroscopy is required and multiple X-rays are taken. Now this is a pictorial view. This is the endoscope and this is the side-viewing lens, and you basically can pass in a cannula and then you can pass in a dye and then you can take pictures. Now this is basically the common bile duct you passed in a dye, and this is the pancreatic duct. This is another view. This is the endoscope. This is the monitors in which you see this is the fluoroscope machine, which basically visualizes the whole. The dye is injected and you can see, as you can see, this is the gallbladder, the common hepatic duct, the right and the left, and this is the pancreatic duct. This is an excellent view in ERCP. MRCP is a non-invasive procedure. It is just like a CT scan, and in that you do not use any dye, basically, and you can just illuminate with the use of computer imaging. You can illuminate the whole biliary system. It is most helpful in obstructive jaundice, in which you cannot use any dye. Now this is the CT scan. This is showing a very large stone which is obstructing the common the cystic duct, which is opening into the common hepatic duct. This is another view. As you can see, there is air in the biliary system. This is basically the gallbladder, and in this view you can see the gallstone, which is actually in the ileum, basically the terminal ileum. As you can see, you cannot see the liver anywhere over here, so this is down, lower down. So basically the stone has trickled and the air is coming from this bowel that has been perforated due to the fistula. Otherwise, there is no normal air in the biliary channels. You can see air in the small bowel. Now, PTC is basically performed. This is also now outdated ever since the introduction of ERCP and MRCP. Now, these are only done in rare conditions where there are some contraindications. So, PTC is basically cannulating the biliary channel from the liver and then pushing in bile. The bile can be aspirated when you pass in a needle to confirm that you are in the biliary channel, and you can inject water-soluble contrast to fill the biliary system. And this is the picture that you will be. This is basically you are cannulating the biliary channel, and from there you will inject you will first aspirate to see that you are in the biliary channel, and then you can take that sample for culture, and then you can inject water-soluble dye and illuminate this whole biliary system. So this is the PTC basically. Spot X-rays may be taken at the same time. How do patients present? There may be fever, right upper quadrant pain, and nausea. Diagnosis basically is patient may be presenting with biliary cholera. The pain is characterized, which is episodic, severe, located in the right hypochondrium or the epigastrium radiating to the back. And this is frequently after food intake and comes at usually night, accompanied by nausea and vomiting. What are the signs that you're going to come across? There will be guarding in the right upper quadrant area along with tenderness. There might be rigidity. Murphy's sign, as I said, is arrest of inspiration, that is with gentle pressure on the right costal margin. That is when the gallbladder fundus is touching the peritoneum, it causes this Murphy's sign. Gauss's sign is basically hyperesthesia of the 9th to 11th rib posterior on the right side. You may have a palpable right tender gallbladder and even tachycardia. Now this is picture showing Murphy's sign. You will place your hand on the fundus of the gallbladder and ask the patient to take a deep breath, and he's going to suddenly wince as you press on the fundus. Now this is again a reiteration. We are going to go very quickly. In acute cholecystitis, there is inflammation of the gallbladder. When the cholecystokinin is secreted in the gallbladder, it causes the gallbladder to contract. If the stones are there, this contraction may cause impaction at the cystic duct. And what are the whole cycle will occur is that there's going to be obstruction, a distension. The mucosa will be distended. When the mucosa will be distended, it will cause bacterial invasion of the immune system, and you will find increased leukocytes in the blood. This inflamed gallbladder may cause peritonitis with inflammation of the peritoneum, and there may be rebound tenderness. When this inflammation occurs, there may be bacterial growth, and the E. coli, enterocoli, bacteroid, all these organisms, that is the intestinal bacteria, may flourish. This may cause inflammation and increase in pressure, leading to pain. And the pain may be right upper quadrant, radiating to the scapula or the shoulder. Now this is again stone impaction and so forth, symptoms occurring. So what is the first option that is occurring? That if the stone may either disimpact and fall back into the gallbladder, just inflammation will occur and the patient may, symptoms may subside. The other thing that may occur if the stones remains impacted at the cystic duct, it will cause inflammation of the wall, and this swelling may either cause sepsis, as we can see that leukocytosis was occurring and so forth, toxemia, Charcot striate will be obvious, or it may perforate. That bacteria may cause ischemic necrosis or ischemia of the small vessels leading to perforation. So if there is no blood supply, ischemia, gangrene may occur, cell death and rupture may occur due to increased pressure also. What are the investigations required? So in the lab, you will find a raised leukocyte count. There might be mild elevation of bilirubin, alkaline phosphatase and SGPT, even PT greater than 1.5 may be there, and mildly raised amylase. So if there is profound jaundice and the picture of acute cholecystitis is there, then you should suspect either cholangitis with obstruction of the common bile duct or Medicis syndrome. What is Medicis syndrome? Medicis syndrome is basically when the gallbladder wall gets impacted with the common bile duct, and the large stone then obstructs the common hepatic duct, the Medicis syndrome occurs. Complications, as I told you earlier on, perforation, peritonitis, pericholecystic abscess, cholangitis, septicemia, pancreatitis, empyema gallbladder, or a gangrenous gallbladder. What are the treatment options? Conservative in case of acute cholecystitis, and then you can do acute cholecystectomy. That may be laparoscopic, that may be open, or you can even do a choledochocystostomy. What is a choledochocystostomy? Cholecystostomy is basically if the patient is very sick, you can just pass in a drain under ultrasound guidance, and you can drain the gallbladder, because you need to decrease the pressure of the gallbladder to avoid pressure necrosis from the impacted stone. The medical treatment sometimes used is oxycholic acid. So what are the, in acute cholecystitis, the principle of management are you need to hospitalize the patient for pain relief, keep your NPO, IV fluids, broad spectrum antibiotics, and either perform emergency cholecystectomy. If the patient is presenting within 72 hours, you can do an emergency cholecystectomy. Otherwise, we do an elective. After 72 hours, you give him conservative treatment, patient resolves, and you can do it after 4 to 6 weeks. The treatment indications are if the patient has symptomatic gallstones or complicated gallstones. There might be silent stones in diabetes or patients undergoing bariatric surgery. I hope you know what bariatric surgery is. Does anyone know what bariatric surgery is? Okay, the treatment, I'll be taking it from the answers that you'll be typing. So please answer what is bariatric surgery. Treatment, medical therapy in which you will try to dissolve the gallstones by using urodeoxycholic acid with a functioning gallbladder, and the stone is less than 10 mm. The dose is 10 to 15 milligrams per kg per day, and pigment stones are non-responsive to medical treatment. So this is not used in pigment stones. Only in case of cholesterol stones are you use this urodeoxycholic acid. Surgical therapy, laparoscopic cholecystectomy is the gold standard now, in which you introduce these 4 ports and remove the gallbladder from this camera port. Whereas in open cholecystectomy, it is not that open cholecystectomy has been obliterated. You still perform open cholecystectomies in unfit laparoscopic patients. In that, you give a parallel coccus incision or right subcostal incision to do an open cholecystectomy. I'm not going to go in detail of this laparoscopic cholecystectomy, only showing you pictures. This is the gallbladder. It is held at the fundus, and you dissect out this Gallstone triangle, as I told you earlier. Now, this is the cystic duct. You have to preserve that, and you have to just clip the cystic artery, which is the content of the Gallstone triangle. You clip the cystic. This is the cystic artery which has been clipped. You should do that first, and then you clip the cystic duct with the 4 clips, 2 above, 2 below, and cut in between. And then you dissect out the gallbladder from the liver bed. Thank you very much. Any questions, please? For 170 and
170.
72. Any questions, please? I know I just rushed into the presentation, but I have a limited time, and since we are not interacting face to face, so I had to give a very detailed explanation on the slides. Now this presentation is available, and you are more than welcome to ask me anything if you want to. I'll be available in surgical 6. What do you mean by fat removal surgery? No, bariatric surgery is not fat removal. Bariatrics means basically obese patients, and obese patients, you do surgery on the stomach, and there are multiple ways that you can reduce the volume of the, as I told you earlier on, the cause of precipitation of gallstones is basically a disparity in the content of secretion that is being produced. So when we were talking about TPN, total power enteral nutrition, there is impaired function of the organ system. So in bariatric surgery, you reduce the volume of the stomach. In that, what happens, all the hormonal secretions are also impaired. So there will be a negative feedback from the from the intestine that the stomach is not that full and the gallbladder is not going to contract properly. When the gallbladder is not going to contract properly, then it is going to cause basically stasis in the gallbladder and stools may form. That is why in bariatric surgery, they always do a prophylactic cholecystectomy also now. And there is a possibility that there might be stone formation in the biliary channel, but that is a delayed process that is not found. But now what they commonly do is that in bariatrics, the cholecystectomy is part and parcel of reducing the volume of the stomach. The basic idea is that in obese patients, since they are in the habit of eating regularly too much, so what they do is they tend to reduce the size of the stomach so that they eat small quantities. If they eat too much, either they're going to vomit it out, or they cannot tolerate it. So that is one of the consequences of bariatric surgery. Anything you didn't understand in this presentation, please? You've got still how many minutes? No, it's past 10 o'clock. So thank you very much. I hope you were able to understand something.